Hey everyone, and welcome to this explainer. Today we're taking a highly structured chronological journey into a really complex yet absolutely fascinating area of pediatric medicine, which is anorectal malformations. We're literally going to trace the entire lifespan of this condition. We'll start by looking at what happens on a microscopic level right there in the womb, then we'll decode the anatomy, step into the delivery room for diagnostics, head straight into the operating room, and finally, look ahead to the patient's long-term future. Let's decode exactly how this congenital condition develops and how modern medicine steps in to fix it. Okay, let's dive into this. Now, anorectal malformations might sound like a super rare edge case, but they actually occur in about 1 in 3,000 births. So, yeah, that makes this a vital frontline pediatric topic. And it isn't just one single type of defect either. It's a whole spectrum of anomalies. We're talking anything from a simple imperforate anus to highly complex malformations that involve the genitourinary and pelvic organs. Because it affects so many newborns, getting a solid grip on the mechanics behind it is absolutely crucial for anyone in the medical field, or honestly, any parent trying to navigate a brand new diagnosis. So, here is our roadmap for today's explainer. We'll start with part 1, the fetal origins, followed by anatomy of the malformations. Then, part 3 covers detecting the defect, part 4 breaks down surgical correction strategies, and finally, we'll wrap up with the long-term prognosis. Section 1, the fetal origins, understanding the pathophysiology. To really wrap our heads around the patho of anorectal malformations, we have to rewind the clock to the embryonic stage. During early fetal development, there's this structure called the cloaca. You can kind of think of the cloaca as a single common channel that handles the developing urinary, genital, and rectal systems all at the exact same time. Now, right around the 6th week of gestation, something critical happens. A structure called the urorectal septum drops down and basically divides that single channel into 2 separate parts. You get an anterior section for the urogenital system and a posterior section for the intestinal channel. But if there's an interruption during this incredibly crucial 6-week window, well, the rectum stops its migration, it just fails to reach its normal position on the perineum, and that sets the stage for the malformations we're discussing today. Section 2. Anatomy of the malformations. Types and variations. The most common term you'll hear in this space is imperforate anus. At its core, this is a malformation where the infant just lacks a normal, obvious anal opening. But, the human body is incredibly adaptive. Because that normal pathway is blocked, the developing digestive tract often creates its own detour. And this detour is called a fistula. It's essentially an abnormal communication or tunnel that connects the end of the rectum to somewhere else entirely. That somewhere else could be the perineum, the vagina, or the male urethra. Because of these fistulas, an infant's first stool, the meconium, might take an alternate abnormal route out of the body. Now, because the anatomy is so vastly different, clinical teams actually categorize the chaos of these malformations strictly by gender. So in males, the defects commonly include perineal fistulas or fistulas that connect directly into the urinary system, like rectourethral bulbar or prostatic fistulas. Over on the female side, you might see rectovestibular fistulas, where the connection opens up near the vagina, or in more complex cases, a persistent cloaca, where the rectum, vagina, and urethra never separated at all and still drain into one single common channel. And it's worth noting, both genders can also present with a true imperforate anus without any fistula at all, or even complete rectal atresia, which is just a total physical blockage. And this brilliantly illustrates exactly what we're talking about. Over on the far left, image A, notice the female cloaca. Look at how the bladder, the vagina, and the colon literally all merge into one single exit point. Now compare that to the middle image, B, which is the low rectovaginal fistula. Here, the bladder has its own exit, but the colon has formed a fistulous tract that merges right into the lower vagina. Finally, on the right, image C shows a male rectourethral bulbar fistula. You can clearly see how the rectum completely fails to reach the exterior and instead just connects directly into the urethra. Visualizing these internal connections is absolutely key to understanding the sheer surgical challenge ahead. Section 3. Detecting the defect, the delivery room. So the first 24 hours of an infant's life are highly monitored, right? Nurses and doctors are specially trained to spot specific clinical signs. The absolute most obvious, of course, is an absent anal opening upon that initial physical exam. But other vital diagnostics include abdominal distension or maybe a failure of the newborn to pass any meconium within their first 24 hours. Clinicians are also going to look really closely at the perineum itself. Oftentimes, these infants present with a remarkably flat perineum and an absent intergluteal groove, that normal midline crease. Now, obviously, receiving this diagnosis right there in the delivery room is incredibly overwhelming for parents, so the clinical team's role here really is to balance rapid, precise medical assessment with deep empathy and support. Now, what's really interesting about this current medical recommendation is that it's kind of counterintuitive. Instinctively, you might think a structural blockage requires immediate emergency surgery, like right then and there. But actually, standard practice is to delay surgery for at least 24 hours. During this waiting period, the infant is kept NPO, meaning nothing by mouth, and they receive IV fluids. So, why wait? Well, it takes time for the bowel to distend enough with air to accurately show the surgeons exactly where the end of the rectum is located on imaging, like ultrasounds or MRIs. It also gives the team 24 crucial hours to evaluate the infant for other issues, like the Factor L association. That's a cluster of cardiac, spinal, or renal anomalies that quite often accompany anorectal malformations. Section 4. Surgical Correction Strategies, the Interventions. Let's demystify some of the surgical jargon here. Historically, fixing these complex malformations required a multi-stage approach. First, the surgeon would create a colostomy to divert waste and protect the surgical area. Then, months later, they'd perform a major surgery called a PSARP, a posterior sagittal anal rectoplasty, to physically pull the bowel through the sphincter muscle. Finally, a third surgery would come along to close the colostomy. It's effective for sure, but grueling. However, modern medicine is just incredible. Today, we're seeing the rise of primary laparoscopic repairs for many of these defects. This means the surgeon uses tiny, minimally invasive cameras and instruments to repair the defect from the inside, often without ever needing a colostomy at all. It significantly minimizes surgical risks, cuts down on postoperative pain, and seriously speeds up recovery. But this surgical correction is really just the beginning. The post-op nursing care is a journey all on its own. In the immediate aftermath, the total focus is just on keeping the surgical incision clean to ensure proper healing. But a key intervention kicks in about 2 weeks after surgery, and that's a strict program of anal dilations. Because scar tissue naturally wants to contract, caretakers have to gently dilate the new anal opening regularly, just to prevent it from narrowing. And interestingly, diet plays a huge role here too. Breastfeeding is highly encouraged for these infants. It's not just for general nutrition, but practically speaking, breast milk causes much less constipation than formula, which keeps the stool soft and really protects that newly reconstructed anatomy. Section 5. Long-term prognosis. Looking to the future. It's super important to be realistic about the long-term issues. The prognosis heavily depends on the child's original anatomy. If an infant was born with poor pelvic muscle quality, which is often indicated by that flat rocker bottom perineum we mentioned, or if they're missing their internal anal sphincter entirely, they're likely going to face lifelong functional challenges. Continence doesn't just happen automatically for these kids. In a lot of cases, it requires a dedicated, proactive bowel management program, utilizing daily enemas, specialized diets, and medications to help the child achieve social continence and avoid any accidents. So the crucial point is captured right here in the clinical literature. Despite the complex surgeries, despite the potential for strictures or the need for intense bowel management, the functional outcome is reported to be excellent. With dedicated medical follow-up and the right management programs in place, these children grow into adults who achieve socially acceptable continence. They go to school, they play sports, and they live fully active, positive lives. It's really a massive testament to the resilience of the human body and the incredible dedication of these pediatric surgical teams. Which leaves us with a final thought to ponder today. We've gone from multi-stage invasive open surgeries to single-stage laparoscopic wonders in just a few decades. So how will ongoing surgical advancements continue to improve the quality of life for children born with complex congenital anomalies? As minimally invasive tech and tissue engineering continue to evolve, the future for these young patients looks brighter than ever. Thank you so much for joining me on this deep dive into the fascinating world of pediatric pathophysiology. Keep exploring and keep learning.